Right, we will continue from where we stopped last week on congenital heart diseases. We've talked about how to classify them. We've also talked about several common ones. We've talked about tetralogy of Fallot. We talked about patent ductus arteriosus, and we talked a little bit on coarctation of aorta. These are common ones, and when we talked about classification, we talked about how they can be grouped according to different features. Yeah, some of them are cyanotic, some of them are acyanotic. We also talked about how to group them according to the shunts, if they are left to right, right to left, or if they are mixed. We also talked about how some of them are stenotic, some of them are regurgitant. Right, that was last week. And remember last week as well, I talked about how what I discovered was that the books and the references that I used to prepare for the classes, the authors tried to match all these classifications. So there are some disparities and discrepancies between literatures, and I don't know which one actually is the correct one, but what I said last week was that I laid everything out as they are, and I leave it to you to decide which one is which at your discretion. So I also promised, or said, I didn't actually promise, but I said last week that I tried to match the classification cyanotic, acyanotic, shunting, and stenotic and regurgitant according to what the ESC, European Society of Cardiology, and how they classify congenital heart diseases, especially adult congenital heart diseases. Um, 1 second, I forgot to charge my laptop. Okay. The ESC guideline did not, or does not rather, classify congenital heart diseases according to how we study congenital heart diseases, and what USMLE, all the board exams, try to teach us, try to classify or group congenital heart diseases, and what they do is to just grade them according to severity. Yeah, and I said last week that if I did not, I wanted to try and group them, group all these two sides, cyanotic, acyanotic, shunting, to get all of that together with how ESC classifies congenital heart diseases, and I did not have time for that, but I already did, and so let me just show that to everybody. Okay, here it is. Here it is. So you see here, I've divided them into the major ones. So you see here, cyanotic, acyanotic, shunting, or the three shuntings, and also stenotic and regurgitant. Okay, what do I want to draw your attention towards? Let's go through the first page. Okay. Let me zoom out a little. I know that you might not be able to see the list of congenital heart diseases. By the way, Nife, congenital heart diseases, there are so many congenital heart diseases, and we are only covering the main ones only, because we don't really have that, we don't have time on our side to cover everything in great details. So let's go to the first page. Cyanotic and acyanotic. Yeah, acyanotic does not mean that it is not. It does not just simply mean that it's not blue. It can be pale and it can be pink as well. Yeah. So what I would like to draw your attention towards is not where they are, or kind of where they are, but how the colors are distributed. Okay. Now, you see that cyanotic and acyanotic. If you notice, the cyanotic heart diseases, They are mainly grouped under moderate and severe. You see more of the yellow stuff is on moderate and severe. So in short, you can say that cyanotic heart diseases, when you see cyanotic heart diseases, you should not treat it lightly because it falls under moderate and severe and it requires plenty of attention. In some cases, even emergent cases. So you need to intervene very quickly, yeah? And acyanotic, you see that they are mostly grouped in mild and moderate. It means so if we were to put some weightage towards cyanotic and acyanotic, I would say according to the guideline, it would be safe if the weightage should be placed. I think it will still be safe to reach to a conclusion that cyanotic heart disease, that the weightage should be placed more on cyanotic heart diseases in comparison to acyanotic heart diseases. Okay, you can see the distribution there. That's what I want to um, draw your attention towards. Now, shunting. You see left to right, right to left, and mixed. Left to right, right to left, and mixed. I remember last week we talked about Eisenmenger syndrome. Yeah, I will talk about that later again. But we've talked about Eisenmenger syndrome as well. So let's go through the first one, left to right, shunting. You see that left to right, it is mostly under mild and moderate. Yeah, and right to left, you see that it is mostly one moderate and one in severe. Mixed, you see that it's in moderate and most of them are in severe. So you can see the weightage here. If we were to match both of these two pages, if you notice the left to right shunting, it coincides with your acyanotic heart diseases. If you notice the mixed shunting, it coincides with your cyanotic heart diseases. I'm not trying to like introduce a new classification or whatsoever, but I'm just trying to point out that there's a lot of ways to classify and there's a lot of ways to match them, and well, depends on how on your creativity or whatever it is. Because remember I said last week that congenital heart diseases, the field of congenital, not just the field, the topic and the study of of congenital heart diseases, both in pediatric patients and adult patients, are still both understudied. So again, this can be a way maybe in the future how we can classify them. I don't know. I'm just throwing it out there. That's what I'm the pattern that I'm looking at. Okay, let's go down to stenotic and regurgitant. What do you see here? Stenotic and regurgitant. Amongst all the congenital heart diseases, you see the stenotic heart diseases fall under mild or moderate. Mild or moderate. And remember, stenotic and regurgitant, the term itself is reflective of valvular heart diseases as well. So, and when it comes to see what we're talking about right now is adult congenital heart diseases, right? And you know as well um, as patients age, or when we talk about the groups of patients, especially when they are 40, 50, 60 years old, they are also predisposed to valvular heart diseases as well. So where does the line fall, whether it is congenital or it is actually valvular heart diseases, maybe secondary to rheumatism? Where does it fall? How do we decide whether it's congenital and or it's secondary to something else? So this is also one of the few loopholes that I think, in my opinion, is still understudied, and we can still figure out how to solve this problem as well. Second, you see that in this list, only stenotic congenital heart diseases are highlighted, where is regurgitant heart diseases? Where is mitral valve prolapse? Where is pulmonary insufficiency? Where is aortic insufficiency, mitral insufficiency, tricuspid insufficiency? Where is it in the list? It's not in the list. And why is how do we then decide if it is mild, moderate, or severe if we meet patients with regurgitant uh, congenital heart diseases, right? So again, this is still another loophole that the guideline has not covered so far that I've noticed. Anyway, that's that. That's that for what I wanna show to everybody. Another classification that I forgot to cover last week. It is not in the guideline. It is not in USMLE textbook. It is also not in MRCP or all of them. But it is in KSMU textbook, therapy textbook. And I think it's, well, as much as it's not very common as what I've seen, I think it's still worth talking or worth pointing out, worth throwing out there, and for you to kind of have a picture. And I think there's also some degree of relevance to it, and as in regards to it being connected to shunting as well. Okay, so what is it? So it is the classification based on pulmonary blood flow, right? Pulmonary blood flow. Under this classification, there are three ways to classify it. First, intact pulmonary blood flow. Second, increased pulmonary blood flow. And third, decreased pulmonary blood flow. Decreased pulmonary blood flow. Intact pulmonary blood flow. Okay, first and foremost, uh, pulmonary blood flow here simply means the backflow of the blood from the lungs because of pulmonary hypertension. It refers to the backflow of the blood going trying to push on the valve, and there's increase in resistance um, on the right ventricle, trying to push blood out into the pulmonary circulation. And because of that, the vasculature of the pulmonary artery becomes thicker. Thus, because of that, the blood flow increases towards as it becomes thicker, as the architecture of the vessels thickens. And this again is related to your Eisenmenger syndrome, right? We'll talk again about Eisenmenger syndrome and just to refresh your memory. So under intact pulmonary blood flow, what is under that? First is aortic stenosis. Second is coarctation of aorta. If we think logically from what we've studied last week, aortic stenosis and coarctation of aorta, for it to affect pulmonary circulation will take a very long time, or something very extremely severe for that to affect the pulmonary circulation. So it is logic to kind of assume the aortic stenosis and coarctation of aorta does not affect pulmonary blood flow, and you can still safely assume that the pulmonary blood flow is intact, right? But in atrial septal defects, ventricular septal defects, and PDA, we see that there is an increase of pulmonary blood flow. That's the second classification, right? ASD, VSD, and PDA, patent ductus arteriosus, falls under increased pulmonary blood flow because, like what we talked about last week, your Eisenmenger syndrome, the three main ones are your VSD, ASD, and PDA. Yeah, and because of the change of um, of direction of shunting from left to right to left, or even bidirectional. So that is why it is logical to assume that an increase of an increase of pulmonary blood flow is related to Eisenmenger syndrome. Thus, the classification falls under ASD, VSD, and PDA, right? Now, decreased pulmonary blood flow, the third one, decreased pulmonary blood flow, pulmonary stenosis and tetralogy of Fallot. Pulmonary stenosis and tetralogy of Fallot. You see that in pulmonary blood flow, in pulmonary stenosis, you know that because the valves are now stenotic, it is difficult for the blood to flow through it, right? So it's also safe to assume that the pulmonary blood flow is reduced because of the stenotic valve, right? And in tetralogy of Fallot, remember, as much as in tetralogy of Fallot, it consists of, number one, what does it consist of? Can somebody remind me? Bye-bye.
VSD.
Hmm?
VSD.
ESD?
VSD non-restrictive type,
Mm-hmm.
right ventricular hypertrophy,
Mm-hmm.
right ventricular outflow tract obstruction, and
Mm-hmm.
or pulmonary stenosis
Mm-hmm.
and overriding aorta.
And already heard that. Okay. Thank you. Well done. Now, remember last week we talked about the exception in Eisenmenger syndrome. That as much as Eisenmenger syndrome affects VSD, ASD, and your PDA, and in tetralogy of Fallot, even in tetralogy of Fallot we have VSD, and but unfortunately or fortunately, whichever it is, Eisenmenger syndrome does not occur in tetralogy of Fallot. Why? I don't know. Nobody, I don't know yet, or people don't know yet. So, and because of that, there is no change in blood flow. There's no change in shunting as well. Uh, so, and you see that it still remains left to right shunt, right? Tetralogy of Fallot, it falls under left to right, right? And if I'm not mistaken, my my brain is telling me, sorry, right to left. Um, right, right to left. And because of that, the there is also decrease because it's right to left, right? Because there's a septal defect there. So it, instead of going up into the vessel, it's going through the septal defect. So you can safely assume that the pulmonary blood flow is decreased in tetralogy of Fallot. Then again, in my opinion, I think that this classification is a bit dangerous to apply, especially when it comes to board exams and all that, because some of them, the placement of such diseases, whether it's increased pulmonary blood flow and all that, I think it's still arguable, uh, and uh, and it's still very dependent on the severity of the congenital heart disease as per the guideline: mild, moderate, and severe. And you know, as it becomes severe, things might change. The pulmonary blood flow might change, and the pulmonary blood flow is not just dependent on the condition of the pulmonary arteriole. There are so many other things that contribute towards pulmonary blood flow. The compliance of the ventricle as well, whether the ventricle will respond to changes in blood flow or not. That is also another issue that we need to consider as well. And there's just so many different factors that play into it, and for us to only safely assume that the pulmonary blood flow increase and decreases, I think it's a bit dangerous to use. So uh, it's I think it will still be good to just stick to our normal cyanotic, acyanotic, shunting, stenotic, regurgitant, and based on the ESC guideline, mild, moderate, severe. I think that will still be. I think that is good enough. I think. Anyway, with that said, with that said, uh, I told everybody that today we're going to continue with coarctation of aorta, VSD, ASD, and transposition of great arteries. As I prepare for today's class, I feel that there's just a lot of things to cover, and if I don't finish them in time, we might have to continue to cover it again next week, and then we might even prolong congenital heart diseases again. So I've decided that today we are just going to finish coarctation of aorta, VSD, and ASD. And what we're going to cover today is the basic things that we need to know about these diseases, not just today, previously as well. Um, it's the basic thing that we need to know, and also I have also included a little bit of subspecialty knowledge on based on subspecialty resources as well. Not in depth, but just scratching a little bit on the surface of subspecialty resources. So just so that we can not just settle on the bare minimum that we need to know, but go a little bit extra to learn. And it I don't think it will hurt to learn extra, right? I hope everybody's on board with that. But anyway, even with that, I think it's a bit it can be a bit overwhelming for some, and it's okay if you feel overwhelmed by it, and if you feel that I'm talking too fast or there's just too much information, just feel free to let me know to slow down, okay? Because I can be talking too fast, and you might um, miss out, or you might fall back, and it's okay to just hit pause. Tell me to hit pause for a bit and go back. It's okay. All right, let us start with coarctation of aorta, right? We talked a little bit on coarctation of aorta last week. We talked about how it refers to general arteriopathy, right? And for some resource from some literature from USMLE and PLAB, their definition coarctation of aorta is a little bit simple, because I think it's the bare minimum that we need to know, the general concept of coarctation of aorta. Based on these two board exams, they say the definition of coarctation of aorta is congenital narrowing of the aorta at any point from the arc of the aorta to the bifurcation of aorta. That's it. But based on the guideline, based on the ESC guideline, it's different, and yeah, it's more in depth, and more. I think that following that definition is good. So the definition again: generalized arteriopathy, and not only the narrowing of aorta. Generalized arteriopathy, not only narrowing of aorta, at any point from the transverse arc of the aorta to the iliac bifurcation of the aorta. So it's not just along the arc, it can be on any side of any part of the aorta as well. Although 90% um, of coarctation of aorta is in reference to your ductus arteriosus, is in reference to that. And I'll explain it a little bit later. Now, let me show you a picture. All right. Everybody can see this picture, yeah? I hope so. Okay. Now, last week we talked about two different types of coarctation of aorta. I've read that there's another one, but okay, generally, just keep it simple, there are two. We talked about one, the one that occurs mostly or mainly in adults, and the one that occurs mainly in children, right? The one in adults is called discrete juxtaductal coarctation, discrete juxtaductal coarctation, and the one that occurs mainly in children is called tubular hypoplasia. Tubular hypoplasia. Or another other names for it is preductal coarctation or infantile type of coarctation. Preductal or infantile. So you see in this picture, preductal coarctation. From what we covered last week, just very briefly last week, in other words, or in it's safe to assume that this one on the left, preductal coarctation refers to tubular hypoplasia, the one that occurs mainly in children. And discrete juxtaductal coarctation is referring to postductal coarctation. Postductal coarctation. Discrete juxtaductal coarctation. In other words, another name for it is postductal coarctation. Now, what is preductal and postductal? Again, I said earlier on, 90% of coarctation of aorta is in reference to your ductus arteriosus, right? What is ductus arteriosus? It is a blood vessel that connects your aorta to your pulmonary artery, and this is seen in infants, especially when they are still um, in they're still in the womb, and also it will just disappear spontaneously um, after they are born, after birth, basically. So again, because it is in reference to your ductal arteriosus, you see preductal here, here's the narrowing, yeah? So this is what it means, preductal coarctation, and postductal is after the patent, the ductus arteriosus, right? Okay, so let's start with your postductal coarctation or your discrete juxtaductal coarctation. We talked about last week that in discrete juxtaductal coarctation, blood flows through the narrowing of the segment, through this narrowing here, normally. It flows through it normally, but there is left ventricular hypertrophy and hypertension. It's left ventricular hypertrophy and hypertension. Blood pressure, and because there are blood vessels that go towards, as it moves closer to the narrowing, the blood pressure around or proximal to the narrowing can increase, and after the narrowing it will decrease. So in other words, you see in this picture over here, your left subclavian circulation, your carotid circulation, and your brachiocephalic circulation over here, whatever that's before the coarctation, before the narrowing, BP will increase. But after the narrowing, you see towards descending aorta already, the BP will decrease. So in other words, when you measure the BP on your upper extremities, it will be different than your BP. It will be, of course, physiologically, it's different. Physiologically, the BP, the especially systolic BP is delayed. Oh, sorry, it's higher on the lower extremities, and pulse as well is slightly delayed in your lower extremities physiologically. But because of this, your pulse can be weak or even absent when it comes to postductal coarctation, and your BP normally in your lower extremities is 10 to 20 millimeter mercury higher than your upper extremities. And in coarctation of aorta, there's approximately about 5% decrease in blood pressure. So when you, and this is what we call pulsus, no, pressure difference, right? We talked about, we've learned it a little bit last time when we were in first, second year, pressure difference. And there's, because of this, pressure will be different, your pulse will be weak, and pulse will be there's pulsus difference as well. Now, if you detect that in on your upper extremities that your right hand, the pulse on your right hand is stronger than your left hand, you can suspect that the coarctation is now affecting your left subclavian artery, right? So if it's affecting that, so it gives you a picture of where the narrowing is. Now, over time, because blood flows through the narrowing normally, and over time, the perfusion, collateral perfusion, not just in your subclavian system, not just in your subcarotid, not just in your brachiocephalic circulation, but also in your heart. Over time, we will try to compensate that. That is why there is left ventricular hypertrophy because of that, and also hypertension as well, because the heart will need to pump more through the more strongly through the narrowing of the aorta, and what plays into the etiology of hypertension in this in coarctation of aorta is not just the mechanical side of of the development of the disease. What I mean is not just the narrowing of the aorta, but also this neurohumoral influence as well, which includes your angiotensin, aldosterone system as well. It plays as well as in this condition as well. So it's again multifactorial, and it would be good, it would be safe to assume that coarctation of aorta, if you see hypertension in coarctation of aorta, it is secondary hypertension and not essential hypertension, right? So because of this, again, the collateral perfusion will try to compensate, right? So some of the arteries will be enlarged, some of the artery will be dilated, and even in the heart, you'll start to hear murmurs as well. Any both systolic and diastolic murmurs and all that. So because of this, when you perform X-ray on a patient with coarctation of aorta, especially in adults. Let me show you something. When you perform X-ray, there is a specific picture that you see. There is a specific picture that you see. Let me see if there is a very nice picture. I should download it earlier. Okay. It's clear now. Second. Okay. This is what you normally see in patients with coarctation of aorta. It's called rib notching. You see the ribs, there are notches on the rib bones. See, it goes in. Can't really see it here, but okay, here, see here. Now, this does not mean that the bone itself becomes rough, because there's no logic in that, right? How are the bones affected by the narrowing of the artery? It's what we're talking about is blood and blood vessel. It's not related to the bone. So what do this notching or this roughness on the X-ray picture, what does it reflect? It reflects it. You can see it because the intercostal arteries are now dilated. They are big. Like I said earlier on, the collateral circulation or perfusion will try to compensate for the narrowing of the aorta, and the most frequent collateral compensation is the intercostal arteries. They are dilated, and that is why you see notching on ribs in your X-ray picture. Okay. All right. With that said, let's go back to this one. Is there any questions so far with adults with discrete juxtaductal coarctation? No? Okay. Let's go to next, the one that occurs mainly in kids. Oh, another thing is that why is the blood flowing normally in postductal coarctation? It's because your patent ductus arteriosus is no longer present, right? So blood flows now mainly through the aorta. It does not go through the patent ductus arteriosus anymore from the left ventricle, from the right ventricle, sorry. Because you know patent ductus arteriosus is connected to your pulmonary artery, and your pulmonary artery is connected to your right ventricle. And your right ventricle, when it pumps out, it pumps through the pulmonary artery into the ductus arteriosus and into the aorta, right? So understanding that in tubular hypoplasia, we're now moving next to tubular hypoplasia, or pre-ductal coarctation, this first picture over here, or infantile type of coarctation. There is severe narrowing of the vessel to a point that it forms sort of like a head and neck. It's sort of like, you know, like a hose. Then it's like a very elongated narrowing of the aorta, of the tube. And it's not just like a notch like in postdactyl. You see, it's just one notch over here, like a pinch. But here it's like a tube itself. The entire tube itself narrows. So it's a severe narrowing of the vessel, extending towards the duct. Extending towards the duct. It's not after the duct. After the duct, I seen what I mean by duct is ductus arteriosus. So what do we see here in preductal coarctation or tubular hypoplasia? Understand that your ductus arteriosus is still present. It's not like in postductal, your ductus arteriosus can be absent already. So understanding that your duct is present, now your right ventricle will pump blood through the duct, right? And it will supply to your descending aorta. It means that in other words, as much as this part is affected, it is still sort of okay because the right ventricle is now perfusing your lower extremities instead of your left ventricle, right? And so the perfusion of your lower extremities is now highly dependent on your right ventricle. So your right ventricle pressure will now increase because of this. And as the patient grows, as the infant becomes older, the patent ductus arteriosus will slowly disappear, right? It will slowly close and disappear. So now, because when it disappears, now the circulation of your lower extremities is highly dependent on your aorta or on your left ventricle. And because it's severely narrowed, your lower extremities can even not receive perfusion. Not receive perfusion. So because of this, there's a phenomenon called differential cyanosis. Differential cyanosis. What does it mean? It means your upper body will be pink and your lower extremity will be blue. Pink and blue because of this. And if this is too much because of cyanosis and all that, this now becomes an emergency. So you have to fix this as soon as possible because your heart will start to fail. There'll be conduction defects. There'll be a lot of arrhythmias and all that. So uh, it again it when we talk about this preductal coarctation, it really is highly dependent on the severity of the patient and of the time as well, because sometimes when the ductus arteriosus, when it's still present, it's not that prominent. So in chest X-ray, you see that the heart will start to compensate. So you see the heart can be big, and that the pulmonary circulation will also become congested as well. Your it also your collateral perfusion as well. You see that it will try to compensate. Subclavian artery will be bigger and more prominent, and there's also notching of inferior border of the ribs. The and all what you see, basically what you see in adult congenital heart diseases, you'll see in preductal coarctation as well, especially when it disappears, especially when your duct disappears. If it does not disappear, if it does not close spontaneously yet, it's still not that severe. So when it closes, uh, you'll see the almost same picture, same manifestation as in adult coarctation, and but it's more severe because the narrowing is now more severe. It's not just like a pinch of the aorta; it becomes an emergent situation. Gold standard to diagnose this will be your echocardiogram, of course, and your ECG. Of course, when you perform ECG, you see left ventricular hypertrophy. Now, how do you treat this? Um, Especially in preductal coarctation, you can give PGE. PGE is there's PGE1 and PGE2. It refers to different type of prostaglandin. PGE1, prostaglandin E1. You give PGE1 to make sure that the ductus arteriosus is still intact. How prostaglandin helps to maintain the ductus arteriosus and not close, I don't know. I don't know yet. But yeah, why do we want to maintain that? It's because we want to prepare for surgery. If in preparation for surgery, suddenly it closes, then if the time becomes we're running out of time. So we need to maintain the duct, make sure that it's still open. Then when we perform surgery, only then we close it. Sure. So to solve coarctation of aorta, mainly surgery, and not much of drugs anyway to deal with that. Okay, that's done for coarctation of aorta. Any questions so far?
Norman. So it's just PGE1, PGE2. They don't use that.
No, yeah, you don't give PGE2, or yeah, I don't. The guideline did not say PGE2. Guideline only say PGE1. I want to show a picture. I don't know if. Okay, here's another picture to show the infantile type of coarctation. You see that this is the aorta, yeah? And this is supposed to be a descending aorta over here. And this is your pulmonary artery. And this is your patent ductus arteriosus. Very big patent ductus arteriosus. I think this picture has problem. But your patent ductus arteriosus is not supposed to be as big as your descending aorta. But yeah, this is sort of just to show that you see your aorta is severely narrowed, and after the narrowing, the descending aorta is not normal, and your ductus arteriosus and your right ventricle is the one that's helping the lower extremities to perfuse. Right. Okay. Can we move on to VSD, ventricular septal defect?
Yep.
All right. Okay. Ventricular septal defect. All right. Ventricular septal defect. It is the most common, um, most common congenital heart disease. Most common congenital heart disease in 1 second. Most common acyanotic ventricular acyanotic congenital heart disease. Now, from the name itself, VSD, ventricular septal defect, it already means that there is a defect in the septum, yeah, and which part of the septum? You know, the heart septum covers both the atrium and the ventricles, yeah, right? So from the name itself, it means that there is a defect in the septum, or in other words, there is a biventricular connection or biventricular communication because of interventricular septal defect. Simple definition: biventricular communication or connection due to interventricular septal defect. Now, the defect can be single or can be multiple. It means that the hole in the septum can be one single hole, can be multiple holes, And this VSD is a component of other diseases as well. It does not just stand alone on itself. Like what we've learned before, it's also a part of tetralogy of Fallot, right? And it's also apparently part of transposition of great arteries as well, which unfortunately we will not be able to cover today because of the amount of content that we have to cover today. Most cases, about 50% of the cases, VSD cases will close spontaneously. The hole will close spontaneously, but another 50% does not close, so it will require surgery for that to close, right? And it's not just congenital. There are some non-congenital reasons as well, and the most common non-congenital reasons for VSD to occur is post-MI. The MI is so severe that the wall ruptures, right? One of the complications of MI. So your VSD can occur MI, post MI, or wall rupture, not just because of MI. Let's say there's a bullet that goes through the heart. Okay, then there's a defect somewhere there too. For example, just not just a bullet. I mean that can be a bit too severe, too dramatic. But yeah, because of wall rupture of the wall. Now, there are types of ventricular septal defects, and I have I have read or I've tried to find different names. I've read different literature on VSD, and I will make your job easier. And I have to preface this by saying that different literatures, they have different names for types of ventricular septal defects. I've read a lot of them and have decided, not have decided, have learned that some of them are synonymous. Some of the terms that you see in different literatures are synonymous to another term, and so I have compiled the synonyms so that when you study again in the future, and if you see that they are not the names that you are learning, then the names that you see in this specific book is different from the name that another specific book talks about, you know that they are actually talking about the same thing. So I would like you to pay attention to the synonyms, because when I learned it, the synonyms kind of got me confused, and I don't want it to get you confused as well. Okay. So in general, the types of ventricular septal defects, the type of defect is the names of these defects. They are in reference to to the part that it is affecting on the intraventricular septum. The part that it's affecting in your intraventricular septum. Now, this picture over here that we see is the intraventricular septum. This is the only picture that I could find that is good enough to show parts of the intraventricular septum. Now you see over here, this one over here is your right atrium. This big one is your ventricle, and this is your pulmonary valve, pulmonary valve, and your pulmonary artery, pulmonary trunk. This is only the right side of the heart, not the left side. Okay, all right. And you see that this one over here, this is the wall that divides your left side and your right side. Okay. When I explain about this, your VSD, and also next when we talk about ASD, I will need your imagination to to kind of picture where the defects are, or where the parts are as well, because understanding anatomy and parts of the intraventricular septum is important, and it makes the job easier when we name types of ventricular septal defects later on. Okay, so if you cannot imagine, or if somehow it does not, the picture in your head is not clear, let me know, and I'll try to explain it to you. Okay, I've I've collected a lot of pictures to illustrate what I want to talk about, what I want to convey, and I hope that you'll be able to imagine, and I hope you are able to picture um, what I want to convey. Also, it's also important, again, I would like to preface by saying that it's important to know which direction that you are looking at. Right now, you're looking directly only on the right side of the heart, not on the left, not from the front, not anteriorly, not posteriorly. This is from a lateral view of the right side. Clear? Okay. With that said, before we go to types of the um, VSD, we need to understand the parts of the intraventricular septum. You see over here, outlet, outlet, and why it's called outlet is because this is where it exits. This part over here, trabecular, trabecular. This part over here, inlet. Why is it called inlet? Is because this is where this is the AV junction, atrioventricular junction over here. This is your atrium. This entire thing is your ventricle. So inlet is where it enters. Outlet is where it exits, right? So the names, they make sense. And this small little hole over here, this area over here, it's got membranous septum, membranous part of the intraventricular septum. Okay, clear? So with this in mind, let's now talk about types of ventricular septal defects. Okay, let's talk about them. The most common type of ventricular septal defect, and it accounts for over 80% of all VSD cases, is membranous type of ventricular septal defect. Synonyms. Again, I would like to emphasize on synonyms because different literatures use different names. So synonyms include perimembranous. First one, perimembranous. Next one, paramembranous. Next, subaortic. Subaortic, you see aorta is here. It's just under aorta. This part over here is the most common one, yeah. Another one, the last name, another synonym is conoventricular. Conoventricular VSD. Perimembranous, paramembranous, subaortic, conoventricular. Now, clear, yeah? Do I have to repeat any one of these synonyms? Okay, no. All right. So even from the name itself, membranous septum, it occurs at the membranous septum. It sometimes may extend to other quadrants of the intraventricular septum. It can extend to outlet, it can extend to your trabecular, it can extend to your inlet. And it is adjacent to your tricuspid valve. See, adjacent to your tricuspid valve. Your tricuspid valve is supposed to be here, but it's not here. And another name for this defect, sorry, I forgot another name, is called Aneurysm of membranous septum. Aneurysm of membranous septum. You know, aneurysm means rupture of something, right? Of membranous septum. This defect can close frequently. Frequently, it closes spontaneously. It can partially close or completely close. Okay. Now, let's move on to the next one. Next defects. Next type of VSD. It's called trabecular VSD. Trabecular. This is the second most common VSD. It accounts for 15 to 20% of all VSD. 15 to 20%. I'm listing it based on the most common one now. Another synonym, another name for it is called muscular type of VSD. Muscular. Muscular, trabecular, the same thing. From the name itself, you see that it's any defects here, it is surrounded by muscles. It is surrounded by muscles and it is close to the apex of the heart. Close to the apex of the heart. It can occur in various locations of the trabecular septum and it is frequently multiple. The defect is multiple. It's not just one hole, it can be multiple small holes. It closes more frequently than your membranous VSD. More frequently, it closes spontaneously more frequently. Next, the third type is outlet septum, outlet VSD. It accounts for about 5% of all VSDs. Synonyms besides outlet: supracrystal, supracrystal, C-R-I-S-T-A-L, supracrystal, subarterial, subarterial, subpulmonary, infundibular, conal, and last but not least, doubly, D-O-U-B-L-Y, doubly committed juxta-arterial. I'll type it out. Chat. Doubly committed doubly committed juxta-arterial. So these are the synonyms for outlet. Outlet: supracrystal, subarterial, subpulmonary, infundibular, conal, doubly committed juxta-arterial. Now, from here, it's clear that from the names, the location is underneath the pulmonary valve, and yeah, because of this, there is a higher risk for regurgitation as well. So naturally, the only one that's remaining is inlet, the last one. It accounts for I did not write that how many percent. I guess less than 1% because most of them are already 20 to 15. Okay, anyway, I'll find out how many percent is in inlet. Inlet over here, you see, it's close to your atrioventricular part, right? So another synonym for it, besides inlet, is AV canal, because it's close to your atrioventricular junction. AV canal. and atrioventricular septal type, defect type, AVSD. It is, from the name itself, you know that it's inferior to your atrioventricular valve as well. I will
Naman,
explain later on that sometimes your inlet VSD, because it sometimes extends into your atria, that is why the name can be called atrioventricular septal defect instead of just ventricular septal defect. All right, let's talk about Eisenmenger syndrome again. We talked about how the left Eisenmenger syndrome refers to the reversal or the change of shunt from left to right to either right to left or bidirectional shunting, right? And we know that VSD is one of the diseases that fall under Eisenmenger syndrome. And so how do we decide whether Eisenmenger syndrome occurs already or not? Because because the change, you don't know when, right? So what do you do? Based on your echocardiogram, you measure your pulmonary vascular resistance here, your pulmonary vascular resistance, and your systemic vascular resistance, and the ratio between two of them. If your pulmonary vascular resistance is higher than your systemic vascular resistance.
Naman, can you repeat?
Repeat which one?
After based on your echocardiogram.
Based on echocardiogram, there are two parameters that you have to measure. Your PVR, pulmonary vascular resistance, and your systemic vascular resistance, because you know your heart pumps into your pulmonary circulation and also your systemic circulation, right? And systemic circulation is based on aorta, pulmonary circulation is based on your pulmonary artery, right? So you measure the resistance in both of these two big arteries, one to the lungs, one to the circulation, to the greater circulation. If your pulmonary venous sorry, not venous, pulmonary vascular resistance is higher than systemic vascular resistance, you can assume that Eisenmenger syndrome has started. The shunt is now changing to right to left, and it's no longer left to right. And when this happens, this becomes an emergent situation. But if your pulmonary vascular resistance is low, it means that your shunting is still left to right, but if it drops again, it means that your shunting is now becomes higher. Either the defect becomes bigger or I don't know, anything that can make the shunting to be increased. So in small, so what that again, I want to point out that the defects, the holes can be small, can be big, can be moderately big. I've searched high and low, what is small, what is moderate, what is big. I cannot find such criteria, or let's say 1 centimeter is considered big, 1 mm is considered small. I can't find such parameters to decide what is small, moderate, and big. So I don't know how to decide that. But anyway, in small vascular defect, small ventricular septal defects, the symptoms can be asymptomatic. In large, patients can complain of dyspnea, can complain of um, uh, poor appetite and because pulmonary circulation is not affected, there's also sometimes pulmonary infection and stuff like that, and also can result to heart failure, of course, definitely. But what are the main highlights that I would like to draw your attention towards, and it is specific to VSD, is harsh pansystolic murmur or holosystolic murmur, the same thing, same name. Pansystolic holosystolic murmur on the on the lower sternum of left sternal border. It means on the projection of your pulmonary um, sorry, projection of your um, no, it's not projection of not your pulmonary area. It is under your sternal under your sternum. Forgot the name.
Apex.
Oh, apex. Apex is on the left side, right?
Yeah.
All right, right, correct. On your left side, yeah, your lower sternal border. So you can hear pansystolic, holosystolic murmur on your lower sternal border with or without trills. And sometimes your S2 can be split. There's wide S2 splitting. Wide S2 splitting.
Norman, can you repeat again?
Harsh pansystolic or holosystolic murmur on your lower left sternal area or border with or without trills, with or without wide S2 split, should I? It's 21 already and we're still on VSD. All right, let's just take our time, okay? Not rush. Let's talk about S2 splitting for a bit. Remember when we talked about S2 splitting last time? We talked about different types of ways the S2 can split. In physiologically, your S2 can split normally, right? And it splits in your inspiration. And also there are different types of splitting: wide splitting, fixed splitting, and paradoxical splitting, right? If you remember, flip through the notes that we covered early on. And you hear S2 wide S2 split in VSD. And we'll, if we have time, we'll talk about ASD. And in ASD, you see that there is wide fixed S2 split, fixed S2 split. And that is very characteristic to ASD, but later on when we talk about ASD. All right, let's stay on VSD. Again, pansystolic murmur with or without trills, S2 wide splits, and the smaller the defect, the louder the murmur is. The smaller the defect, the wider the murmur is. So in chest X-ray, you see that there is enlargement of the heart, pulmonary edema, as you know, as expected, right? And ECG, you see left ventricular hypertrophy, again as expected. And your gold standard for diagnosis will definitely still be echocardiogram. Transesophageal echocardiogram will be better. All right, treatment. Treatment is dependent on the size of the defect. In small defects, it can spontaneously, there's a chance for it to spontaneously close in 1 to 2 years, because again, it's asymptomatic, right? Most of them is asymptomatic and there's not much for us to be alert about. So, and again, I would like to reiterate by saying that muscular defect closes or trabecular defect based on this picture closes more frequently, it's more likely for it to close rather than your membranous defect. For moderate and large defects, definitely surgical intervention, and also we need to be prepared for heart failure as well, treatment for heart failure. Again, what constitutes small, moderate, large? I can't find that. I don't know what is considered small, what is considered moderate, what is considered large. So again, also in the guideline, it's not stated there. So the guideline itself has problems. So anyway, if you're interested, I'm just going to throw this out there. If you're interested, there are a few indications for surgical intervention. If the patient fails to thrive, fails to try to cope with it, if the patient, if medical treatment is not helpful, or the defect is very large, and there's pulmonary hypertension and all that. Of course, looking at how emergent these situations can be, of course, surgical intervention is naturally the best choice, right? I would like to throw this thing out right here, what I'm going to talk about next. And it's one of the criteria to decide whether surgical intervention is necessary or not. It's called Fick's equation. Fick equation, F-I-C-K, Fick equation. It sort of involves a little bit of math and some formula. This is, again, a little bit extra, and this already falls under specialty, the knowledge that we need in our specialty. And in this equation, you'll find QP and QS, and ratio between QP and QS. If you're interested, you'll find out that the ratio, when the ratio is above 2, and above 2 for children, and above 1.5 for adults, that is indication for surgical intervention. Next will be, as we all are aware, this involves the endocardium, right? The innermost layer of the heart. That is why in the future, as much as this defect is solved, we still need to be aware of endocarditis as well. So for whatever reasons, whether even if the patient wants to go and do any dental things, want to extract their tooth, or want to do stuff in their mouth, have to be aware of endocarditis prophylaxis as well. We talked about endocarditis prophylaxis here. So yeah, if you are not familiar with that, just flip through our old notes. We talked about how to administer prophylaxis for endocarditis. Okay, this is VSD. Let me show you some pictures just to illustrate. Okay, you see here, outlet, yeah, outlet. Over here, perimembranous, paramembranous, cornoventricular. See here, over here. Muscular, see over here, can, again, like I said earlier on, it can be multiple. This is what it means by multiple holes. It looks a bit creepy. So yeah, and this is inlet. You see over here, inlet. Close to your atrioventricular junction over here. This is your right atrium. Okay, the rest of my pictures are all ASD. Any questions so far for ventricular septal defects?
No.
No? All right. It's 8:28. Obviously, we don't have time to cover atrial septal defect, as I thought that we'll be able to cover that. Well, time is not on our side. Anyway, so what do you guys want to do? Do you want me to type the notes out for atrioventricular atrial septal defect, or would you like me to continue next week on atrial septal defects, and and if we have time, we'll start GIT next week.
Norman, if you type it out, can you hear me? Is my network good?
Yeah.
Yeah, if you type it out, I think it will be better. If there's an area maybe we don't understand, maybe next class we can ask questions.
Okay. What do the rest of you think?
I agree. I was going to
Agree?
say that.
Okay. Anybody who has a different opinion, it's fine too if you have a different opinion. Oh, I'm just gonna throw this out there. If you prefer that I explain it, I don't mind explaining it to you. We can set a time and we can talk about it. If you prefer a verbal kind of explanation, because I understand that different people, they learn differently, and if visual kind of reading kind of thing is not very helpful, and if you need more explanation, I'm willing to explain. We can set a different time aside from Monday, of course, um, to do that. But if you would like, if majority prefers that I explain to everybody next week on Monday, it's fine too. What do you guys think?
That sounds good too.
Which one sounds good? I just throw
The
multiple
one that you
things.
said. The one that you said.
Another class aside from Monday.
Mm, yes, the formula. Or we can continue next Monday and then plus GIT.
Okay, Aka said another class. Another class meaning like another day in a week. Okay, she said yes.
Maybe for those who are interested.
Okay. Yeah, true. For those who are interested too. Yeah, for those who are interested. Maybe for some of you, CVS is already a bit dry. And
Norman, I have
hmm, you have question?
I, yeah,
Davai.
about VSD. So VSD is not a trilogy of palette.
VSD itself.
Or must okay, VSD is always associated when palate is diagnosed. Yeah. But
Yes.
tetralogy of palate does not necessarily have to be with VSD if
No.
VSD is diagnosed.
N-
Ah,
no. If you want to diagnose tetralogy of Fallot, you need all that four components. But
okay.
VSD itself, without the rest of the components of tetralogy of Fallot,
Mm,
can exist on itself.
okay, that's all. Okay.
Okay.
Naman,
Mm.
uh, if you find any task regarding this topic, can you share?
Clinical
Like,
task.
yeah, clinical task.
Mm, okay. Okay, I'll find. I can find.
Thank you.
Write it down before I forget. I need to find task. Okay. All right. So wait, what are we going to do next week?
I like having another class aside from Monday.
This another class will only be on ASD. You're saying only on ASD.
Yeah. Also, if we can also have the written
Maybe we can have it this week and we can finish that, and next week we can move on to JP.
Harasho. Okay. So let's do this way. All right. So I'm going to I'm going to write it down. I'm going to have everything in written form, and we're going to have a separate class on ASD that is not on Monday. So next week, in other words, so the conclusion is next week our class will be on GIT. We'll start on GIT, and ASD will be just like an extra class.
хорошо.
Is that okay
Sounds
for
good.
everybody?
Yes. But
Okay. With that said, when can we have the extra class?
Tomorrow.
Tomorrow. Tomorrow I can.
What about anyone?
I'm okay with tomorrow. Is everybody okay with tomorrow? Anybody who's interested? All right then.
Is it just one class, Norman?
Yeah, it's
Is it
only
for tomorrow?
on
Only
ASD.
for ASD. It's not
Yeah,
as if
only
next week Tuesday we're also going to meet.
no, yeah. Next week Tuesday we won't meet.
Okay. Okay.
Just tomorrow, just to cover ASD. Is that okay?
Tomorrow by what time?
Okay, so tomorrow by what time?
We can do it